So Liverpool is where you're headed tonight, right?
Yeah, I'm getting on the
Flying
plane
back.
tonight.
Can you fly? You fly direct to Liverpool from here?
Fly to Manchester, and then, in fact, I was hoping to go direct to the lab, but I'm going diverting slightly to the BBC studios to talk about the Ebola outbreak.
That's
which,
right.
As you know, there's been a lot of interest in.
It's ongoing as we speak. I don't know when we're releasing this, but it's been ongoing since March, right, of this year?
Yeah, February, I think the first cases were. Yeah.
So let's talk a little bit about that. That's a virus that gets in the brain.
Yeah,
right?
it does, although that's not the main problem with Ebola.
Right. So why do you think the outbreak has spread so extensively in Africa?
Yeah, this has, so as you know, this has been the biggest outbreak with now more than 900 deaths and approximately 1,800 cases. And there were some initial concerns that maybe there's something different about this virus, but we know now that's not the case.
It's been sequenced, yeah.
But the problem is it's all about how people respond when there's an outbreak. So this is the first outbreak in West Africa.
Right.
And essentially what we're seeing is the same kind of panicky, fearful, anxious response as we saw in Central Africa when outbreaks first happened 35 years ago. So basically when people are getting sick, instead of going to see the medical authorities and getting help and getting the treatment that might save them and being put in isolation so that they don't spread the disease to others, they're doing the opposite. They're running scared. It means that their families end up looking after them, so their families then get sick because, as you know, the virus is spread through bodily secretions. And, you know, unfortunately, this is what's characterised the whole outbreak. And I think there have been a couple of key moments as well. So it's, you know, it's bad enough to have all that happening. But I think the things that certainly really triggered a response in the UK and when the government asked us to start looking at it was two things that happened. Firstly, the doctor, one of the local doctors who was supposedly leading the campaign in Sierra Leone, sadly got ill and died from Ebola. And, you know, that triggers the response and the thoughts, well, you know, if he can't protect himself, then what hope is there for everyone else? And then the other thing was for the first time it's been transported or transmitted via a passenger on an airline plane, someone who picked up the disease. He was an American Liberian, got sick in Liberia, got infected in Liberia, didn't realise he was sick, got on a plane, came to Nigeria, and as he got off the plane realised he was sick, and he sadly died as well.
Has he transmitted it to anyone in Nigeria?
There's been some secondary cases in Nigeria as well now. I think a doctor and a nurse, I think there's 4 or 5. So this is worrying. I don't think there's any doubt about it being worrying. And as you probably know, the World Health Organization are meeting today. They've got a sort of an emergency response meeting to decide on what the international response should be.
So when you travel and you don't know you've been infected, and that's an easy way to infect other people at the other end, obviously, right? Yeah,
I mean, easy and not easy. So there's there's quite a lot of confusion in the media about how infectious this is. You know, it's not a respiratory pathogen. It's not like the guy on the plane is going to be coughing over other people and passing it like that. So no one on the plane got sick. But the people who get sick are the medical staff who try and look after you when you're bleeding, vomiting, diarrhea. But again, the important thing is we know how to make sure that doesn't happen. We know that if the medical staff are properly wearing the full protective equipment and have been trained in how to use it, how to wear it, how to decontaminate, then they won't get sick. But again, unfortunately, you know, when this guy got off the plane, as I understand it, the first responders, if you like, they obviously don't have that equipment available, and they did their best. But it's very sad for those who.
Now, in Guinea, in Sierra Leone, and Liberia, in the hospitals there, are they gowning up completely?
Well, this is one of the problems. So there have been at least 60 deaths now among healthcare workers, and all those healthcare workers have been people who unfortunately didn't have access to the full equipment. So they're wearing gloves, they're wearing masks, maybe aprons. And you would hope, you'd like to think that would protect you, and it should protect you, because this virus doesn't bore its way through the skin, you know, but it gets in through cuts, it gets in through mucous membranes, and the problem is all of us all the time, even if you're wearing gloves, you know, if you're not careful, you touch your nose, you scratch your eye, and if you've got Ebola on your fingers, that's how you're going to get infected. At least that's our current understanding.
You were telling me before, even if you have a gown, you have to know how to take it off.
Yeah, you have to know how to take it off, because if you think about it, if you take this thing off in the wrong way, you're not careful, you'll be touching the outside of it, with your, if you take your gloves off first, for example, and then you take everything else off. So you need training, and, and people buddy up and help each other get the gowns on and off, make sure they decontaminate.
Now, as you know, a couple of Americans were infected and flown back to the U.S. For treatment.
Yeah.
Is that a good idea? A lot of people here are going nuts over it.
Yeah, I know. Well, I've been following the news media, and in fact, I've done a few interviews with people like Associated Press and some of the other agencies. Well, I think there's several issues there. The first issue is about the treatment they were given. They've been given this drug called ZMapp, which is a humanized monoclonal antibody. It's a cocktail of 3 antibodies. Right. It works in, or at least it appears to work in the monkey model. It's been given to, I think, 8 primates. It was given relatively soon after the virus was given, so I think within 24 hours, within 48 hours, certainly before the monkeys got sick. But it seemed to be effective. Yeah. And then on the basis of that, it was given on a compassionate basis to 2 Americans who got sick in Liberia. Yeah, I mean, and they've both done relatively well. They then were brought to the United States, and they appear to be doing well. So, but whether that's the treatment, or whether that's the natural history,
N equals 2, it's too small.
But I don't know. I mean, is there anything wrong with bringing back your expatriates who are sick? We do it for other conditions. One of was it Trump? I think Donald Trump said that they should be left to sort of rot in Africa. Yeah. What was his expression? Maybe you don't want to go into this on Twitter. I don't know.
I don't know what he said.
But basically, I don't think it was a very helpful comment. Yeah. And you can be sure that if someone like him was sick in Africa, they'd want to come home.
Well, in your country, you would bring citizens back and treat them.
Yeah, of course we would. It's what you do. I mean, but I also actually think it's a smart move anyway, because if you are sitting in the United States and you're worried that someone might get off a plane with this, just like they did in Nigeria, well, isn't it better to have had a bit of a heads up about how we manage it? How do we do our procedures? How do we care for people? So I don't think I think it's a sensible thing to do. But there are issues around the use of these drugs.
Sure. I mean, and this is why we need to have BSL-4 labs to study them and vaccines, because you need to have challenge experiments, which you can only do with virus. Yeah. You can only do so much with pseudotyped viruses and so forth. You have to have Ebola virus in an animal model, and that has to be done in a BSL-4. And as you may know, right now there are some people in the U.S. who are calling for a shutting down of BSL-4 in 3 labs.
I have. I find it extraordinary, but I mean, this country is extraordinary in so many ways. But so I've come. Well, I was at Harvard before I came here to be with you, and I don't think I'm spilling any secrets here. That I think it's pretty well known. They have a BSL-4 lab there, but
in Boston,
in Boston. But they've I think have had some difficulties to be able to do the kind of work that you want to do in those facilities.
It's not opened yet.
Right.
The NEEDL, the National Emerging Infectious Diseases Laboratory.
And do you know why it's not opened?
Yeah, because the neighborhood has been objecting.
Yeah.
And,
so that is well known. So I mean, that's nuts, though, isn't it?
Absolutely.
Yeah.
I visited it actually and did a documentary a couple of years ago. It's a wonderful facility. Yeah. And we need places like that, and that's where the Ebola and Marburg and Lassa therapies will come from.
Of course.
So I don't understand why people don't get it. I guess we don't do a good enough job communicating that.
Well, that's why. I mean, it's true, actually. I think one can blame the public, but really it's our job. And is it any wonder? I mean, you've got to, you and I have both been doing media work in the last few days, trying to sort of get a sensible, balanced message out there. And there are some really good journalists, really good reporters who really want to do that. But then there are also people who realise it makes a better story to have a dramatic headline and to make it all sound scary. And then if that's what people think, then no wonder they're not going to want people working on that pathogen. But I think the other issue around the new treatments is how we move from developing and designing new drugs, which people are doing. I think the American government have invested quite a lot in that in recent years, which is great. But how you move from there to actually knowing which drugs are effective in humans.
It's hard, yes.
And this drug's been used on a compassionate basis. There are calls now for using these drugs more widely, but I really think we're not quite approaching the whole situation the way we should. The regulatory hurdles that we make for clinical trials are, they might be fine for some, tablet that somebody's going to take once a day for the rest of their life to deal with their itchy feet.
Right.
You know, but that's not what we're talking about here. We're talking about the need to get potential treatments into clinical trials where they're needed very quickly. And so
Sure.
all the steps that we normally go through, you know, for example, the phase 1 testing, which is to see, you give it to volunteers and you see is it safe in them.
Right.
Well, let's take ZMapp, or let's take any other new drug which is being developed. Do we really care whether it causes headaches and a bit of fever in healthy volunteers? No, we don't.
No, because these people are good
dying from
likelihood
this
to
disease.
die. Yeah.
So, you know,
Yes.
we have to cut through some of that.
Well, that's what happened when AIDS emerged, right?
Yeah.
The FDA was going at its usual plodding rate,
Yeah.
and the patients said, "We need
Yeah.
drugs."
Yeah.
And that became fast tracking.
Yeah.
Which
it needs
is
to be
good.
fast tracked. I mean, the sad thing is that the African people living in villages are not really, they don't really have this voice, this advocacy for fast track. Hopefully their governments will push for it. And although we don't want to detract from the important message about, you know, this disease will be controlled by public health measures, by people isolating themselves, not spreading the disease, etc. That's the most important message. But on the other hand, if we are going to develop treatments, we have to take, the only way you're going to see if a drug works is by trying it in a clinical trial during an outbreak.
Do you think that there's a place for a vaccine? You know, the incidence isn't huge, and you could argue that a good antiviral or monoclonal therapy might be enough.
I certainly think vaccines should be developed. Quite how they would be used and who they would be used in is hard to know. But I think we need a sort of a dual approach. We need to develop drugs and we need to develop vaccines. Nobody's ever going to suggest we vaccinate the whole of West Africa.
Of course.
That wouldn't make sense. But, you know, if we had a vaccine now that we could do some kind of ring vaccination or mass vaccination.
Yeah. When there's an outbreak,
you can do that.
Exactly.
But of course, the problem is, and this relates to, so you may have seen some criticism in the media that says, you know, it's more on the web, you know, it's the conspiracy theories, it's the angry mob. Oh, why were these secret drugs only reserved for Americans? Why weren't they given to Africans? You know, there's a sort of bit of a hullabaloo.
Yeah.
But that's inappropriate. Basically, the situation is we can't even convince these frightened villagers who've never come across anything like this before to come to hospital to have simple drips, which we know will increase their chance of survival.
Really? An IV drip? An IV drip. Just saline?
Yeah, if you get fluid into people and stop them going into shock, they die of shock. They become dehydrated, they become acidotic, their metabolism's deranged, their organs shut down. They don't die from bleeding, usually. And we know that the mortality rate's 90%. But if you treat people, you get them early and treat them with fluid, you don't save everyone by any means, but the mortality drops to about 60%. So, but if you think about it, if we can't even convince people to do that, then it would be totally inappropriate to be going with an experimental drug and saying, try our drug. And of course, you'll remember the HIV stories where people felt that HIV was being trialled in Africa, you know, for the West's benefit.
Polio vaccine.
Yeah, and they were being used for guinea pigs. So I don't think so I don't think, you know, even if we had a vaccine now, let's say we had a vaccine today, could you really imagine trying to get that into the communities that need it? It would be really difficult.
You know, this is really important to remember. People here and in the UK have a different view of healthcare. They think, you just go to the hospital and you get treated, but it's not the case clearly because people are afraid, as you said, and if you do go to hospital, you're not always going to get the appropriate care.
Exactly.
Right?
So part of the work, part of the research we're doing through our health protection research unit, starting to do is to understand these behaviours. You know, in fact, it comes back to the same thing we talked about for managing brain infections in the UK or in America. It's all about how people behave. What governs how a doctor behaves when they're faced with a patient? What governs how a villager in Africa behaves when their, you know, husband has got sick? So there is a role for studying these things, because ultimately, if you study people's behaviour, you can change it.
Yeah, absolutely. It's not something I think most people think of.
It's not what your average molecular virologist spends his time worrying about.
That's right. So you have plans to go to any of these Western African countries?
Possibly. Yeah, we're putting together a team to go out there.
What would you do?
Well, so we have people there at the moment through our unit. We have people on the diagnostic side. So there's the diagnostic virology lab. We have people on the public health side, working with governments there, advising on outbreak control. But actually, what is also needed is just sensible people on the wards, clinicians, who can help look after patients, put drips in, etc. So, and we have, I don't think we've got discussion back in Liverpool at the moment. I don't think our most junior doctors, I wouldn't send them, I don't want them going. But sensible people like Lance and others who've worked overseas, who can stay calm in a difficult situation, who can follow the training, and who can, it's not rocket science in terms of the medicine, it's about putting drips up, giving fluid, acid-base balance. It's what we've all done in our past, in our training. I haven't done it for a few years, so there's a bit of a debate about whether people like me would be useful. On the one hand, I've done, because I still do a little bit of work overseas, I'm probably a bit fresher than many of my consultant colleagues. I wouldn't go out myself without, again, spending a bit of time on ITU, just getting up to speed.
ITU being?
The intensive care unit. But also I have a sort of policy in my institute, is I don't ask people to do things that I'm not prepared to do myself, be that stay up all night working on a paper or writing a grant, washing up the coffee cups, or maybe going out.
Yeah.
And then the other thing is, if we're serious about trying to set up some of these studies to look at treatments, and we've worked on these. I've done treatment trials for hemorrhagic fevers before in Asia. I've done trials with new antiviral drugs in Japanese encephalitis. Then it'd be helpful to go out there and try and work with the African doctors and the governments to work out what the best approach would be.
Well, good luck if you do go.
Thank you very much.